Actually, that's a really good point, and we're going to talk about that a little bit during the talk as well. But palliative care is just excellent holistic care. It is looking after every aspect of the person, not treating the disease, but treating the person. And that goes from physical to psychological to social to sometimes financial. Every aspect of a person's life it comes under the heading of palliative care. In the past, when people would Google palliative care, often the definition that would come up is end-of-life care. And that's something, thankfully, that has changed over the course of time. And I'm just going to go over that as well when I'm talking about it. The one thing that I just want to add right now is that I'm aware that we are all in different countries with access to sort of different services and different medications. I'm going to try and talk through different challenges as well that we might face. So thank you, Shani. I can see the slides now. Next slide, please. So I want to tell you a little bit about myself. I come from Pakistan, from Karachi. The picture on the top right is from my last holiday, although that's a screenshot from something else, but that was Lake Saif al-Muluk. And I am very interested in cricket, following the current Pakistan Super League season, if anybody's following that. And my other interests include Lord of the Rings, the Star Trek universe. I'm teaching myself how to play the piano, so just different aspects in life. The three pictures at the bottom actually are quite useful to just think about as well in terms of overcoming adversity, teamwork, the importance of thinking outside the box, which I suspect Babar Azam has to do from time to time. So it'll just kind of help us during our talk as well when we're talking about different challenges. Next slide, please. These are the two sites of the Royal Marsden Hospital, and I have to say I'm very grateful that I have the opportunity to work in such an incredible organization. But yeah, next slide, please. So our aims today are to consider what is palliative care, why it's important, and then to think about some basic symptoms, including pain, nausea, and vomiting, and constipation. I know that there are a multitude of symptoms that our patients face, but in the interest of time, I'm going to try and stick to these three for now, but we can talk about anything else that you guys want to talk about in the discussion as well. Lastly, we will talk about death and dying and, you know, the importance of sort of thinking about deterioration and how we can talk about it. And I think it's important to talk about death and dying because it's super important to manage that as actively as any other phases of illness. Next slide, please. So the concept of understanding the way the human body works goes back to Egyptians and Babylonians. And this practice has evolved over the centuries to give us the Hippocratic Oath, which itself has gone through several permutations to give us the modern day oath that some of you might have read or agreed to at the beginning of your careers. The essence of the oath continues to include the emphasis on healing the physical concerns as well as psychosocial care, ensuring the balance of compassion and appropriate medical care while acknowledging and respecting the limitations of modern day medicine. Taking this a step further, in the mid-20th century, the hospice movement pioneered by Dame Cicely Saunders, that's her picture there, in the UK, and by Dr. Kubler-Ross in the USA instigated the idea of looking after patients with advanced life-limiting illnesses in a compassionate and holistic way, with emphasis on early and careful management of their symptoms within a multidisciplinary team, and care for the patients and their families at the end of their lives. Next slide, please. So the modern day definition of palliative medicine, which is described as a multidisciplinary approach to delivering excellent clinical care aimed at the prevention and relief from pain and other sort of physical, spiritual, and psychosocial concerns for patients and their families facing life-limiting illness. Despite this definition, I suspect in a lot of places, palliative care is still aimed at patients at the end of their lives. So the WHO have kind of tried to write it in a much more organized way. But I think possibly we can all agree that we're still falling short of it. Next slide, please. So why is it important? I'm going to just give you guys a few seconds to read that. That's from this gentleman, Atal Gawande. And if any of you have a chance to read that book, Being Mortal, I think it can resonate quite close to home sometimes, but I'll just give you a few seconds to read that. So having read that, I mean, it's important to think about the fact that palliative care is explicitly recognized under the human right to health. It should be provided through person-centered and integrated health services that pay special attention to the special needs and preferences of individuals. Palliative care is required for a wide range of diseases. I know Shani and I work in a cancer center, but you know, every sort of life-limiting illness is going to need palliative care. And the majority of adults in need of palliative care have chronic diseases such as cardiovascular disease. So about 38.5% of patients who need palliative care have cardiovascular diseases, cancer, chronic respiratory diseases, AIDS or HIV, and diabetes. And many other conditions can require palliative care, including kidney failure, chronic liver disease, multiple sclerosis, Parkinson's, rheumatoid arthritis, or sort of neurological diseases, dementia. So you can see the list is almost unending. Next slide, please. So as I said, we're going to talk a little bit about symptom control, and I'll stick to sort of pain, nausea and vomiting and constipation, but I'm happy to talk about anything else at the end if you guys want to talk about that. Next slide, please. So pain is just one of the aspects of suffering in patients with life-limiting illnesses. Other aspects of suffering also have a major impact on the way patients experience and express their pain. Therefore, I think efforts to alleviate all those other physical, psychological, social, and spiritual factors that contribute to pain expression are quite pivotal. And inadequate assessment of those is a big barrier to good and optimal relief. Pain should not be managed as an entity, but as part of a sort of multidimensional suffering component that needs to be properly assessed and managed, ideally by a multidisciplinary team if available. Next slide, please. So history taking is a key component of patient assessment, enabling the delivery of high quality care. Understanding the complexity and processes involved in history taking allows us to gain a better understanding of patients' problems. Socrates is a useful mnemonic acronym used by healthcare professionals to evaluate the nature of pain that a patient is experiencing. And a lot of us would have come across this in our training years for a good pain history, but I think you can apply that to quite a few other things as well. Before I go into the details of that, I think it is important to recognize that the most obvious things need to probably be addressed first, as in that little picture that you can see. Thinking about the different components of Socrates, so sight, get the patient to point to the area of pain. Onset, has it started suddenly or has it been increasing gradually over a period of time? Characteristics, so is it throbbing, is it cramping, is it burning, is it dull? And those can actually give you really good answers sometimes to the kind of problem that you'd be dealing with. Where is the pain radiating to? That can also pinpoint the exact causes sometimes if we think about liver disease and radiation to shoulder tips, or celiac plexus disease radiating through to the back. So it can be quite useful. Is it associated with anything else? Does the pain get worse when we are doing anything in particular? And time, how long does it last? Any exacerbating or alleviating factors? Does anything make it worse? Does anything make it better? Severity, is it mild, moderate, severe? And I think it's really important to think about the severity, because one other question I always tend to ask is, how is it impacting your life? It's all fine that, you know, a patient tells us that there's a little bit of pain in his, for instance, his right foot. Okay, imagine if that person is a train driver whose right foot is the main thing that controls the train. You know, just thinking about the impact that the severity is having on the person's life. And it's not part of Socrates, but it's important to think about the fact that listen to the patient. Pain is what the patient says it is. It is as severe as the patient feels it is. I am certainly guilty of sometimes not taking some of the symptoms as seriously as I probably should, because they don't fit into my pre-existing idea. We talk about sites of pain or any of these symptoms and whether they fit in with what we know about the location of the disease or the extent of the disease. It's important to think about that, but I don't think we should be confined by that idea. And I think the other thing is, does it need further investigation? Now, before we move forward, I think, and Shani and I talk about this all the time, is that it's really important to manage expectations. Promising someone that we can take away their entire symptom is, I think it can be quite tricky, and I think it can be disingenuous as well, because we have no guarantee, no matter what medications or what resources we have at our fingertips. I don't think we should be promising that. So managing expectations is always quite important. The one thing that we can promise people is that we will try our best. And I think that that can be quite a reassuring thing. I know some people might disagree with that. That might not be good enough for them, but I think the majority of people find that quite reassuring. Next slide, please. So the WHO analgesic ladder was a strategy proposed by the World Health Organization in, I think it was 1985 or 1986, to provide adequate pain relief to cancer patients. Again, I want to talk about the fact that even though this is about cancer patients, but a lot of these tips and tricks can be applied to other kinds of pain as well. So chronic pain or pain from arthritis. The one thing I would always advise against is this is not necessarily a great way to manage acute pain or post-surgical pain, because we know that, you know, that is coming from a different pathology almost. So we need to be mindful of that. This path developed following the recommendations of an international group of experts. It's gone through several modifications over the years and is currently applied for managing cancer pain, as I said. But they do talk a lot about degenerative disorders, musculoskeletal diseases, neuropathic pain disorders. The efficiency of the strategy is a little bit debatable. And despite all of the work that's been done in pain management, it's yet to be proven through large-scale studies. So if anybody asks you about the evidence behind this, I would unhappily tell you that actually there isn't a lot of robust evidence behind this. Nevertheless, I think it still provides a simple palliative approach towards reducing morbidity due to pain in about 70 to 80% of patients. We talk a lot about going back to basics, and I think the WHO Pain Ladder is a brilliant way of thinking about that, that whenever we get stuck, it's useful to think about the steps in each direction. The original ladder mainly consisted of 3 steps. So the first step was mild pain, using non-opioid analgesics such as non-steroidals or paracetamol with or without adjuvants. Again, be mindful of what you are thinking is mild pain and what the patient is thinking could be described as mild pain. The second step is moderate pain. So thinking about weak opioids like codeine and tramadol with or without other medicines like paracetamol or non-steroidals. And the third step is severe and persistent pain. So thinking about stronger, more potent opioids like morphine, methadone, fentanyl, oxycodone, with or without non-opioid painkillers as well. The key concept of the latter, I think, is that it's essential to have adequate knowledge about the pain to assess its degree in a patient through proper evaluation and to prescribe appropriate medications, as many patients will receive opioids eventually where they can have access to opioids. It's essential to balance the optimum dosage with the side effects of the drugs, and I'm going to talk about some of the side effects a little bit later. It's also important to consider a bidirectional approach with regular review and escalation or de-escalation of medications according to the symptoms. Where there are challenges in accessing opioids, it may be useful to consider interventional techniques for symptom control like nerve blocks or epidurals if you have access to those. Next slide, please. So as the class name suggests, non-steroidal anti-inflammatory drugs reduce inflammation. They're not related to steroids, but they can reduce inflammation. And they work by reducing the production of prostaglandins, which are chemicals that promote inflammation, pain, fever. They're grouped together because of their analgesic and antipyretic and anti-inflammatory effects. And the good thing is that they don't depress the central nervous system. So thinking about some of the challenges we might face with opioids is that there is no risk of physical dependence or abuse. This is quite a big problem right now going on in the US, if you've heard of the opioid crisis or you've followed any of the Netflix programs about that. Non-steroidals are weaker painkillers than morphine or oxycodone, but I think they work better with inflammatory pain, and certainly in a lot of the cancers we deal with, including sarcomas, they can be quite useful. We just, again, have to be mindful of the side effects that I'll talk a little bit later. They primarily act on peripheral pain mechanism, and to some extent, they cross the blood-brain barrier, so they can have an effect in the CNS where they raise pain threshold. Next slide, please. So we would all have used non-steroidals in our practice, thinking of Nurofen or ibuprofen or diclofenac or Voltarol, or if you're as old as I am, if you think back to the COX-2 inhibitors and rofecoxib and celecoxib, before some of them were taken off the shelves for other reasons. They differ in potency and duration of action, and it's useful to be mindful of that when we are dosing them. So medications that can be used once a day, twice a day, or 3 times a day. They also differ in tendency to cause ulcers and risk of bleeding. And that's because they differ in their relative inhibition of the cyclooxygenase 1 and 2 pathways. It's interesting, although they're very similar in action, some people respond better to one non-steroidal as compared to another, and the causes for that still remain unclear. Their side effects can include things as serious as strokes, hypertension, GI ulcers, bleeding, kidney failure, and bronchospasm. And I haven't worked with this current group of participants, but certainly in other teaching sessions, I go on and on about the GI effects and the bleeding risks and the risks of renal failure with non-steroidals, because a lot of services use non-steroidals very routinely post-surgery. I know for a fact that post-knee replacement in some of the biggest hospitals in Karachi, the normal practice is setting up a continuous infusion of ketorolac. And we've seen people have very severe bleeds ending in death as a result of that, or renal failure ending in death as a result of that. So it's really important to review regularly, and no matter what is going on, whether they're having side effects or not, do not continue long-term, because there is now strong evidence that continuing them long-term can have a higher cardiovascular risk. So there was a European review done in 2013 that talks about that and increasing the 10-year risk of cardiovascular events. Consider stopping the non-steroidal if the pain is not responding to it, like with any other medication. So just important to be mindful that if I've started somebody on ibuprofen 200 3 times a day, I need to think about the fact that they're on ibuprofen 200 milligrams 3 times a day. Next slide, please. So I think you might have skipped a slide, Shani. Sorry. So morphine. We've all heard of morphine. It's the first choice of strong painkiller for moderate to severe pain, according to the WHO, as well as the European Association of Palliative Care. It's a natural opioid. It's derived from the poppy seed and acts on opioid receptors both centrally and peripherally. And the shorter acting preparations given orally work within, the evidence says 30 to 60 minutes. I would argue that I think it can be about 15, 20 minutes at times. And the shorter acting preparations can last for about 4 hours. We do now have long acting preparations which can last for 12 hours. And I know that in the US, they have some that can last for 24 hours. So it's once a day dosing. Oral route is always the first choice, but it can be given through other routes as well. So subcutaneously, IV. And where you do have access to morphine, the usual starting doses are all of the practice guidelines say 10 milligrams 4 hourly, but I would be slightly cautious of that. I'd probably tend to start people at 5 milligrams 4 hourly even if the patient is already on opioids, if it fits with what they're on when we think about conversions. I don't want to go into conversions here because I know that we all have access to different medications. Next slide, please. So the next strong opioid is oxycodone. It's a synthetic opioid. Now, late 1990s and early 2000s, when oxycodone came onto the market, it was advertised as, you know, the best opioid ever, greater bioavailability than morphine, fewer side effects. I think last 2 decades have taught us that it has a very similar way of working to morphine, but about 70% of patients who might have side effects with morphine may respond better to oxycodone, and the other way around as well. And that was a trial done by Professor Julia Riley at the Marsden, I think it was 2011 or something. Oxycodone is metabolized by the cytochrome P450 pathway. So it's really, it can be useful because it has a different metabolic pathway, but I think you really have to be quite cautious with liver failure because there is a higher risk of side effects. Next slide, please. So thinking about some of the common side effects of opioids, a lot of people will talk about nausea and vomiting, a little bit of drowsiness or unsteadiness. And these are things that are quite common and tend to settle down either with a good antiemetic on board. Drowsiness and unsteadiness can actually settle down in a matter of a day or two, actually. The common ongoing side effects can be constipation, nausea and vomiting, and a dry mouth. And all of the international guidelines talk about giving concurrent laxatives and anti-sickness medications for these side effects. Some people might have some excess sweating or itching or hallucinations, myoclonus and urinary retention. And these are things, maybe not so much the sweating and itching, but the hallucinations and myoclonus and urinary retention are things that always make me think, I need to be mindful now because I can't push up doses anymore. And if I do need to push up, do I need to think of an alternate opioid? And some of the rare and sometimes life-threatening side effects can include respiratory depression or psychological dependence as well. And I would absolutely put down psychological dependence as a life-limiting side effect because It may not affect physical life, but certainly psychological effects long-term can be quite detrimental. Whenever we are starting people on opioids, it's useful to consider their renal function, because there is a higher risk of side effects and toxicities with poor renal function with morphine and oxycodone. If we do have a patient with poor renal function, then other medications like fentanyl and alfentanyl may be more helpful. Next slide, please. So now coming to nausea and vomiting. I love asking people when I'm teaching about nausea and vomiting, what do you think is nausea? What do you think is vomiting? But I'm mindful that we've got a big audience, so I won't go into that. Nausea is essentially the subjective experience of an unpleasant sensation that someone's about to vomit. And vomiting is the actual expulsion of gastric contents. It's a significantly distressing symptom for patients and for those close to them. And it can be acute or anticipatory and actually can develop into a chronic issue. Certainly at the beginning of my practice, I don't think I took it seriously. I'm going to put my hand up and say that, you know, unless somebody was actively vomiting, and I was worried about how I was going to get a medication into them or how they were going to eat or drink. Nausea, we try some things, but I'm not sure I would actively chase it as a symptom. It's important to consider the cause. And again, going back to the basics, what's going on with the patient? Is it physiological? Is there some organ failure, or are they simply constipated? Do they have a raised calcium? A lot of people get motion sickness. And I think just the presence of metastatic disease itself, even if it's not affecting any of the organs, can cause nausea and vomiting. Medications, so cytotoxic chemotherapies, antibiotics, opioids, digoxin can all cause problems. So then there can be infective causes like food poisoning, norovirus, general sepsis, and some psychiatric causes as well, including nausea, depression, and some eating disorders. Next slide, please. So obviously, when we've thought about the causes, it's sometimes easier to cater to the exact cause, and we're lucky that we have a good few anti-sickness medications. I'm not going to go into the deeper pharmacology because I love talking about nausea and vomiting and the medications, but that can take up to an hour, so I won't go into the details of that. But if somebody wants to email me later on, I'm happy with that. So metoclopramide, obviously, one of the main ways it works is that it speeds up gastric transit. So stasis, gastritis, functional bowel obstructions can be treated really well with that. Domperidone, I would probably include under the same heading as well. The only difference being metoclopramide can be given IV or subcutaneously. Domperidone is an oral preparation. Chemical causes of nausea and vomiting respond really well to haloperidol, and those can include opioids, renal failure, or a raised calcium. Raised intracranial pressure can respond well to cyclizine. It's important to be mindful of the fact that if somebody does have intracerebral disease, automatically they would be at a higher risk of seizures. So actually medications like haloperidol, levomipramazine, they can actually theoretically lower seizure threshold. So the one safe anti-sickness in someone with brain disease, I would consider to be cyclizine. So nausea and vomiting secondary to chemotherapy can respond well to aprepitant, ondansetron, and dexamethasone. And dexamethasone can be very useful alongside one of the other medications. In case someone's not come across aprepitant because it is still a relatively newer drug, I just want to reassure that I've managed to start somebody on aprepitant in Karachi. So it is available there, and it can be very useful because a lot of the radical treatments that patients are receiving, so thinking about radical radiotherapy and chemotherapy for a curative breast cancer or lymphomas, things like that, where the treatment is so intensive that patients actually think about coming off the treatment because of how sick they are feeling. So it's very important to keep pushing the limits of what we can give them to try and manage their symptoms, both to get them to eat and drink better, but also to take away that sort of miserable feeling of feeling sick all the time. Next slide, please. So I don't want to frighten anybody, because I get frightened when I look at this picture, but it helps me fit in some of the drugs with the receptors. And I'm happy to share these slides at the end of it as well. If you're thinking of particular receptors, the medicines can fit in quite well. One thing I would just say is that there are times when we're not necessarily restricted. So it might be that something is not making sense. There is no reason why somebody who's got a high white cell count in the setting of chronic myeloid leukemia would respond to a medicine like metoclopramide, for instance. It's a purely metabolic cause. There are no issues with the GI tract, but it does. So when you've gone through the kind of problem-solving steps of this, and you've tried your haloperidol and levomipramazine and things like that, do think of the other antiemetics. Like I said, anything that works. When things are not following our plan, then sometimes it can be useful to ditch the plan and just try whatever we can. Next slide, please. So constipation. So I just want you guys to think first about what constipation means to us. Historically, especially when the gastroenterologists were dictating the definitions of constipation, they had a very specific thing of, you know, somebody hasn't moved their bowels for 3 days, or they're passing hard stool. You know, they were quite restricted by that. It's important to ask the patient what their normal pattern is. Some people do actually move their bowels once every 3 days. That's normal for them. So it's important to think about what constipation means to the patient. It's also important to think about the causes then, because those are the things that can help us sometimes in trying to treat the constipation, whether it is to think about, can we correct the cause? So if you think of hypercalcemia and actually you've given them a medicine to control their calcium, actually it might be that some of the other symptoms do settle down themselves. Opioids, as I mentioned when I was talking about opioids, constipation is a very common side effect, and approximately 60% of patients become constipated when they're on opioids. A lot of the other medications that we give people quite routinely, so amitriptyline, hyoscine or buscopan, cyclizine, a lot of the anticonvulsants, they can all cause constipation. And again, when we are starting people on these medicines, it's important to keep asking about bowel habits and if there have been any changes. Poor intake of food and fluids. I think dehydration is such a common cause, and actually rehydrating a patient can change things around quite quickly. Then inactivity, and that is almost self-explanatory. If a patient is not moving around too much, then all of the systems would slow down. And then some chemotherapy agents like vincristine can also slow down the bowels quite a bit. Now, when we're thinking about constipation and we're thinking about the causes and we're thinking about starting people on laxatives, it's always important to rule out bowel obstruction. And again, this may be more relevant in the cancer setting where somebody has abdominal disease and they are at a risk of bowel obstructions. It's almost always important to rule it out. If they don't have anything that could be causing bowel obstruction, then perhaps this isn't as relevant. Next slide, please. So management tips for constipation are actually the usual ones. So considering increasing dietary fiber, fluid intake, exercise, having a look at the medications that they're already on, and then thinking about laxatives. So those can be bulk forming or stimulants or softeners. If oral laxatives are not working, then enemas and suppositories can be quite useful. On very rare occasions, and I'm going to say that in my 8-year practice of palliative care, it's only once that I've had to give somebody methyl naltrexone to reverse opioid-induced constipation. Naloxegol is used quite commonly in some countries, I know, and it can be quite helpful in terms of controlling the effects of opioids. One thing I always think about is, it's all fine, I'm writing up all of these laxatives. Is my patient going to actually have them? Are they able to? Do they have nausea and vomiting? Do they have pain? Are there other things that could stop them from having these wonderful drugs that I think will instantly solve their problems? So just useful to be mindful of the route that we are recommending and whether the patient will be able to use that route. We are actually quite limited in that there aren't a lot of laxatives that can be given IV or subcutaneously, unfortunately, apart from methyl naltrexone, as I mentioned, or enemas and suppositories. So if somebody has other problems with oral intake, we are a little bit limited with how much we can do with oral laxatives. Next slide, please. So advanced care planning, I just thought it's useful to think a little bit about advanced care planning before we come to death and dying, just because it's important to recognize deterioration and talk about it. So just some useful tips for you guys. Next slide, please. When you have somebody who may have a life-limiting illness, or they, if you have the time and they have the time to think about future care planning, then simple things like, what do you know about your health problems? What might happen in the future? It can be quite useful. The other thing is, what matters to the patient? What are they worried about? I can talk about my family quite openly because they know I talk about them quite a bit when I'm teaching. I think that sometimes the patient voice is not always heard because everybody is in a hurry to give the doctor the information and almost talk over the patient. But sometimes listening to the patient's voice gives you all of the answers that you are looking for. I still remember when my father was in hospital and, the doctor would come and see, and when they saw me, they'd be like, how's he doing? He'd be the first one to speak up and say, I've got a voice. I'm able to answer you myself. You don't have to ask the other person. I know sometimes it might not work, but it's just something to think about. That brings us nicely to the other thing. Who should be involved in discussions about changes in someone's future health and care? I come from a massive family. Everybody has an opinion. Everybody has thoughts. And so it can be, and I'm sure a lot of you guys would have faced this already, where you're having to talk to 7 different people about the same issue. And 7 have to listen to 7 different opinions and considerations. So just, if we can identify it at the beginning, and I find it quite useful to say, I'd quite like to have one point of contact, but if anybody else has questions, set aside some time to answer those questions. When we are bringing somebody into hospital, talking about outcomes of admission, expectations, what treatments they might get, so IV antibiotics or surgery or interventions, because healthcare professionals are in a very definite position of power. A patient is at his most vulnerable. They will listen to whatever the doctor or the nurse tells them. They will say, or the doctor is saying, I need to have this intervention for the stroke. They might not want to, but just because the doctor is saying it, it is, it can again take away from listening to the voice of the patient themselves. So talking about it beforehand can be quite useful. Treatments that will not work or have a poor outcome for this person. And this is a conversation that we have almost on a daily basis, because things like CPR and emergency management are so glamorized by Grey's Anatomy or ER or Holby City, you know, that somebody has CPR and they're up and about, and next day they're going and playing football, if anybody was watching last year's World Cup. It doesn't happen. I think that when we are talking about CPR, then we have to think about the post-treatment effect. So where is the person going to be at? Are they going to be bedridden and not, you know, they're not going to be able to get back to their usual life? Some people do, and actually that's why it's delivered. But if we are mindful of it, then we can talk about it quite openly. Proxy decision makers. So I was talking about that above in terms of who should be involved. But the other thing is that we talk about a proxy decision maker in cases where the person loses capacity. Sometimes even when people have capacity, either they're not allowed to express themselves, so there is an automatic proxy decision maker, or they don't want to, and that's okay as well. When we are feeling less well, there are times when the 7 different healthcare professionals are asking the same set of questions, becomes very tiresome. So there's no harm if a patient has identified someone, even when they're well. There's no harm in sort of taking that into consideration. And then help and support for family and informal caregivers. The patient is at the center of what we are doing, but actually looking after the family is part of looking after the patient, because they are part of that person's existence. So it's quite important to think about that. Next slide, please.
Ellie, we're coming up to 10 minutes left.
Sorry, yes, I'll be very quick. So tips on starting conversations about deteriorating health. I'm just going to read this out. So I wish we had a treatment if we're thinking about advanced cancer, but could we talk about what we can do if it's not possible to treat the cancer? I'm glad you feel better and I hope you stay well, but I'm worried that you could get ill again. Can we talk about how we manage with not knowing exactly what will happen and when? So again, bringing uncertainty into the center of the discussion. If you were to get less well in the future, what would be important for us to think about? And some people want to talk about whether to go to hospital or to be cared for at home. So I've used this from the SPICT website here. It's a useful one to look at if you guys want to talk about advanced care planning. Next slide, please. Next slide, please. So I was going to talk about this, but we've already talked about it a little bit before. And sometimes when we don't have a cure, only a salve, what can we offer? Any interventions, no interventions, just compassion? Death and dying, I think we all have to do quite a bit of all of that when we can't control things. Sometimes it is useful to remind people, not in an unkind way, but it is useful to remind them death is the one certainty when a person is born. Even taxes are not a certainty anymore. Death is the one common sort of factor that is common to all of us. We know we are going to die at some stage. Next slide, please. So thinking about recognizing death and dying's early stages, like loss of appetite, somebody's not able to take their medications, general weakness, sleeping a bit more. Then probably a bit more of a progression when they lose their swallowing function or there is a decrease in their mental alertness. And the last stage, probably I would say hours to days before death, is changes in their breathing, skin mottling, and loss of consciousness. For those of you who work in critical care, I think things that could be useful to just think about are hypotension refractory to any amount of inotropic support that you can throw at them, or cardiac failure refractory to support, or renal failure, which is a subject very close to my heart. Irreversible delirium, advanced cachexia. So those can be quite useful stages. And actually sometimes quantifying those things can be quite useful for families as well, because I know that a lot of us come from a society where death and dying is a taboo subject. We don't talk about it. We don't think about it. But sometimes families can respond quite well to somebody not being able to do something to stay alive. Next slide, please. I apologize. I was trying to, I've used this as one of the things from a document that we use at the Royal Marsden Hospital, and it's how we would deliver care on a daily basis. So communicating and documenting with family, clarifying aims of care, and it's useful to do that very regularly. Reviewing interventions. Is a statin that changes a 10-year risk of stroke useful for someone at the end of death and at the end of their life, really? Can we take away some of the burdens of regular interventions that might not be useful for somebody? And again, communicating those decisions and involving families and patients in those decisions. Then maintaining excellent basic care, mouth care, bladder and bowel care. Can they have oral food and hydration? If they can, how can we get it into them? If they cannot or they don't want to, not to force them. And that's something that I know a lot of us struggle with quite a bit. Ensuring dignity and compassion in all care. Then the fourth thing is assessing symptoms regularly and prescribing medications as required if we have access to them. And thinking of other ways of delivering the medicines for good symptom control if somebody is not tolerating oral medications. Advice from your local friendly palliative care team if you have access to them, that's always good. Identifying support needs for the family. So a lot of people ask me, you know, my sister's in Australia, should I ask her to come over? I tend to say to people, look, if you have somebody who's far away, please get them to come over. I'm happy to be wrong. I know that that's a very simplistic way of looking at it. But another thing I say is make the decision that you will regret the least. So while sometimes we're waiting for people to become more unwell so that we can get family over, things can change quite suddenly. And it's important to just think about that. Spirituality, so documenting any specific actions required or referring to you know, chaplaincy, if that's something that you can offer. And then aftercare, so trying to think of things afterwards quite quickly. Just because a person's death doesn't mean that the care has ended. So certifying appropriately, making sure that anything that's important to the family, that we are thinking of those things. And then post-bereavement, and that's something that we've talked about yesterday a little bit, and I was going to talk about that as a challenge. Next slide, please. So some challenges, expectations regarding end of life. What happens? There are times when people ask me, what's going to happen when I'm actually dying? And you talk a little bit about symptoms, and the thing you talk about the most is the fact that they're not going to be alone when they have to face those symptoms. Prognosis, to discuss or not to discuss, I think that is something that we have to deal with on a case-by-case basis according to what the patient wants. Balancing hope and reality. And this is quite important because a lot of patients will tell us, I don't want to talk about anything else. I just want to be hopeful. I have hope that I'm going to get better. And I always say to people, I'm not here to take away your hope. I want to make sure that you know exactly what's going on right now. You know exactly what we are trying to do for you. And that we share your hope that things will get better, whether in symptom management or cancer treatment, but we always share that hope. Unfortunately, we may have a bit more information or experience about things not working as well as we want them to, but sharing hope is important. Access to medications and expertise. And I know Raza mentioned this yesterday, and that's, I think, whenever you don't have access to a particular drug or expertise, going back to the basics can be very useful. Thinking of other ways of dealing with symptoms, thinking of interventional techniques or other things like acupuncture, mindfulness. People tell me nausea and vomiting responds really well to mindfulness. I don't know the evidence for that. So, and my email address is there if I can be of any help at all. I know that there are some palliative care specialists in Lahore and Karachi now that provide a good service as well. So think about that. And then bereavement counseling. This is a challenge that I think I could probably talk to you for another hour after this, but what do we do afterwards? And we're quite lucky that most of us have patients with big families who can help support. But loss and death never go away. Losing a loved one, I'm not going to heal from that. There will be scar tissue that will always remind me, and I'm not sure I would want to heal from that. I want to remember. So, but how I manage that and how I support my patients manage that, yeah, ongoing work needed. I think that might be the end of the talk. Next slide, please, Shani. Oh, yes, I was going to talk about this. This is Elizabeth Kubler-Ross, who was one of the bosses of palliative care in the US. And she talks about the reality is that you will grieve forever. You will not get over the loss of a loved one. You will learn to live with it, and you will heal, and you'll rebuild yourself around the loss you have suffered. You will be whole again, but you will never be the same, nor should you be the same, nor would you want to. And I just find that incredibly powerful. And I know that when I've suffered bereavement, that's something that now makes absolute sense. I think that might be the end of the slides now. Would you check
I think
for me,
it is.
Shani?
I think thank you. I think the last slide is for discussion. Thank you very much for such an amazing overview of the symptoms and the challenges facing symptom control. Facing our patients, actually, and obviously the challenge in delivering them. I appreciate 1 hour is such a short time to discuss everything. And
I'm sorry.
No need to apologize. I know I'm just mindful of the time, and I'm just checking, although we officially have 2 minutes left, whether there is time maybe to extend for a few, maybe to 5 minutes for any burning questions from the panel, from anybody else, or if anybody wants to share any experiences or ask any questions. Just to start, I'm just going to quickly say, and I'm grateful everybody's attended, everybody's got different backgrounds, but the 2 burning questions that people probably say is, look, you've talked about a fantastic service that you're able to deliver. What can I do if I don't have a palliative care service? What happens if I don't have the drugs? What do I do? And because that's the bottom line, isn't it? Well, we've got an established service, we can deliver this, and it's really, really good. It works really well. As an oncologist, I say that without palliative care symptom control team, I can't function. And that's not just for patients who are deteriorating. I actually like to involve you as a team very, very early for patients. And these are patients who are both incurable, but also for some of our curative patients as well. They need their symptoms controlled. This is not just from the disease, it's also from my treatments, because it's about toxicity from treatments. So it's about making sure we balance that. So what can we do if we haven't got access to palliative care? What can we do about setting it up? What can we do if we've got the drugs? Because I'm sure that's what people are thinking. And in the chat, if anybody else wants to put any questions or even just join us for a quick discussion. But Layla, over to you.
So you've asked me 3 very big questions, Shani. You've asked me about
3 one-line answers in 30 seconds.
One-line answer. So one-line answer for what do we do if we don't have access to medications? Going back to basics, using medications that you do have access to. Do not ignore basic medications like paracetamol, non-steroidals, codeine, tramadol. Thinking of neuropathic agents like the gabapentinoids, so pregabalin. Do not ignore these medications, because I'm not saying that they will solve everything, but they might solve some of the problems that we have, and think outside the box. So I know that doesn't fit with going back to basics. Those are 2 different things, aren't they? But think outside the box as well. If you've gone through the WHO pain ladder, you've tried to escalate things appropriately, you're getting stuck, then heat therapy, cold therapy, physiotherapy, TENS machines, acupuncture. I'm not such a fan of the chiropractic practice, because I find that those can actually cause problems sometimes. But everything else I've mentioned, those are things that we can think about to manage those symptoms. The thing to do is to continue to ask, what have we done? Has anything helped? I never ask patients, the medicine I started you on, is your pain better? That's a very closed question. I'm not sure I'm going to get a good answer to that. But whatever you are doing, Has it made any difference? If it hasn't, do you need to consider anything else? That was the first thing. If you don't have access to a service, then there are actually basic things that you can do yourself. And it is about considering the symptoms. You might have noticed a lot of the things I've talked about, I've not actually talked about anything new. These are probably things that all of us already know about, but we don't often have time to consider those questions. So I think building in time into those consultations where you have problems, you don't have access to a lot of things, you don't have access to a service that could help with those things. But if next time that person is coming to see you, whether building in an extra 15 minutes might provide you with some more information, that can be useful. Palliative care guidelines are not common. A lot of services have their own guidelines. But if you do know somebody in another hospital or another city or another country, those are things that can always be shared. Information governance dictates that I can't be responsible for somebody having input, you know, let's say in Dubai, because I don't have a license to practice in Dubai, is the easiest way of putting it. So actually, if I'm saying start somebody on 20 milligrams twice a day of morphine, I can't be liable for it. You would be if you are living in Dubai and you're the one who's prescribing it. So that's why it's, you know, WHO guidelines, NICE guidelines, EAPC guidelines, they can all give you a little bit of an idea, but always talking it through with another person and trying to understand their point of view. That's something that can help solve some of these problems. How to set up a service, I think, is a question that we all need to think about together. If we don't have a local service, what do we need to do for it? And you need time, you need expertise, and you need access to those medications and those services that we are talking about. So I would be open to any other thoughts and ideas that you might have about that.
I'm actually going to throw that question to the attendees who've all kindly, you know, sat here with us for the last hour. What you know, I thank you for everybody's comments they've posted. You know, I think, you know, do we all feel that there is a need to be able to offer our patients some kind of service, and how can we best set it up? And, you know, would people be interested in maybe we should set up some kind of workshop in the future, Leila, through SIVU and various, you know, supporters, but that's something that would be interesting to get feedback even afterwards. I think Dr. Sinzadi's got a question. Maybe you can actually, sorry, I can't read, for some reason I can't read the chat. What's your opinion? And then I can't read the next thing, is about spiritual support.
Yes.
Sorry.
Yeah, that's a really good question. I think it's really important that we keep our own opinions about our beliefs separate from what our patient believes in. Trying to identify if they have any spiritual needs is quite important. There are some services I know where they will have a local imam who is able to go and talk about, you know, the nature of life and what Islam has to say about that. Other faiths have their own sort of chaplains who can provide that expertise. I'm going to say that in my experience, nobody's looking for an answer. When we talk about, right, so-and-so is getting spiritual support, they're not getting any answers. If they are facing a life-limiting illness, they know they're facing a life-limiting illness. They know that nothing anybody can say or do will change the eventual outcome. But they can get some reassurance. You know, some people find it quite reassuring to know that, yeah, that's what God has written, that's what God has said. I would take this a step further, Dr. Zaidi, and just add, there are people who are self-proclaimed atheists, and they're like, yeah, after I'm dead, there's nothing else after that. Those are the ones I find quite challenging, because I have a very strong faith. I have my own beliefs, and I'm like, how can you say that? That's not true. Maybe if you talk to the imam, you might, but it's about making sure I don't impose my own thoughts on somebody. So I think spiritual support can be very helpful if somebody is struggling to deal with their disease, because a lot of patients find that having a life-limiting illness can shake their faith and their belief quite a bit. So it can be quite useful. I don't know if that answered your question.
I'm just waiting to see if there's a thumbs up from Mr. Zaidi.
Okay.
Does anybody else have any questions? Because there's a whole list of questions I could ask. Does anybody else want to just ask anything before we end the seminar? Okay, so what I'm going to do then is I'm just going to thank Dr. Kamal, Leila, thank you very much for giving us this, kind of initial overview of symptom control. And I always call it symptom control rather than palliative care, because patients sometimes get a little bit tetchy and upset thinking they're immediately dying, because symptom control is not just reserved for patients who are actually actively dying. It's actually for all, I think, cancer patients. So all patients who actually have symptoms, actually, you could argue, that are not controlled by their other teams. I think the key here is to get early referral to the symptom control team, ideally setting up a symptom control service or seeing what we can do in the future. And not to be worried about asking questions. One last thing I'm going to say is, before I started oncology, I always thought patients can get addicted to morphine, even if they're cancer patients, and we know that's not true. So that's one of the myths that you've all kind of been able to address that. So there's lots of myths about symptom control palliative care. But thank you very much. I know there's a lot of work to be done nationally and internationally. It'd be really good if we could set some platform or forum up to be able to promote this really huge unmet need. But thank you very much again on behalf of everybody who's attended today. And thank you everybody for attending and for your patience. Brilliant. I think what I'll do is I'll let us end the seminar, and I'm sure we'll I think we've got some requests for people to submit to the encyclopedia. And Dr. Khan, you've been asked if you might be able to help us with a section on symptom control and maybe death and dying. I think it would be ideal to get your expertise on that.
Happy to help. Thank you so much again.
Brilliant. Thank you very much again, everybody, for attending, and I look forward to the next seminar. I can't promote that because I haven't got the information. Professor Zaidi, maybe you can tell me when the next one is. So whilst we've got a captive audience, is it next week or is it later on today?
So we have a series of webinars. Mubashir has a list. It's usually every 2 weeks. We have a clinical webinar in 1 week, and the medical education the next week. So we'll publish it. If you go to CVU page, you will find all the details. So this, Leila, it was superb. I have to ask you to write a full chapter with Shani, if you like, or with Raza, on breaking the bad news and terminal care, palliative care and terminal care for the Islamic Encyclopedia of Medical Ethics, which you are writing with Kufa and Najaf universities. So it's a global thing. I have about 40 chapters at the moment. I need about 20 more before we start publishing it.
Thank you, Professor Zaidi. I will definitely discuss that further with you. But thank you. That sounds like an amazing opportunity.
Superb talk. Thank you for handling it, Sean. You did so well. You should come more often.
Thank you.
Brilliant. Thank you, everybody, for attending again. And I'm sure we'll get your certificates and any feedback. Bye-bye. And thank you, Sir SIBU, again for hosting us today. We're really grateful.
Thank you.